Let me touch your chainsaw.
Well, good morning. Thank you, Dr. Burns, for allowing me to speak today. Special thank you to all the ACS and trauma attendings who taught me over the past year and were mentors for me. So this presentation was originally a case presentation, but we've extended it to the full hour so that we can talk about Reboa, the past, the present, and the future. And I think the picture there will become a little bit more evident as we go forward. So I have no disclosures. This is a brief outline. We're going to go over a case presentation, a little bit of the history of Reboa, some of the current literature, and some of the future uses and studies. So about a year ago, we had a 46-year-old male that was clearing to have a pulse, started CPR. By the time that EMS got there, there was a pulse. He was a GCS of 3 and unable to be intubated. On arrival, he was still a GCS of 3, bradycardic in the 40s, quickly lost a pulse while we were intubating him, so we started CPR. He had bilateral finger thoracostomies, massive transfusion was initiated. After a round or two of CPR, he had return of circulation. He had a fast exam that showed gross blood in Morrison's pouch. This is not his fast exam, but a representation of a fast exam where you have liver, kidneys, and a lot of fluid in between. Reboa catheter was placed fairly quickly, and he was taken to the OR. All this occurred from the time he got to the door to the time he got to the OR in about 20 minutes. This is a quick x-ray that we got right before we left. You can see here, this is what the Reboa balloon looks like. It's filled with contrast, so this is up in the aorta. The tip of it here, which is also a very large zone 2 hematoma. At the time of the operation, this did not appear to be expanding, and there was a question as to the Barker vac was removed, and he underwent a left nephrectomy. Barker vac was again placed, and he was taken to the ICU for further resuscitation. There's a list of all of his injuries there, mostly spleen, left kidney, and bilateral chest trauma. This is his course, having a decent amount of oozing coming from both his nephrectomy site and his splenectomy site. Those packs were removed, and post-op day 3, his abdomen was closed. Over the next several days, he had an early tracheostomy, and then chest tubes were slowly removed. His tracheostomy was downsized and then decannulated, and he was discharged to Siskin. He's presented back to clinic. He's doing well. He's back to his normal activities and approaching pre-hospital weight. He's been back to the trauma ICU several times to talk to the nurses. He looks like a whole new person.
When did this happen, Tyler?
This is about 8 months ago.
Okay, all right.
So a little bit of the history and story of Reboa, and I think it's a kind of a fascinating history. And it's really one of conflict, both in its development and what they did is they found 23 patients that were dying from hemorrhage. 15 of these were trauma patients. They had 5 ruptured AAAs and 3 that they included in the other category. And they inflated these balloons. At the time that they inflated these balloons, only 9 patients had vital signs. 6 patients lived. 4 of the 5 vascular patients lived. 2 of the 15 trauma patients lived. That's 80% survival for the vascular patients, and somewhat at the forefront. This is Dr. Rasmussen on the left. This is pictured in 2004 in Afghanistan, and this is Dr. Ellison on the right, 2005. And they figured that they would improve on Dr. Hughes' previous work. There's been a lot of advancement in the vascular world with aortic occlusion balloons. This is the CODA here. It's been used for years in order to gain proximal control in AAAs, but it had downsides. It required a huge sheath. Depending on the balloon that you used, 10, 12 French, it required an open cut down, it required long wires, it required fluoro. It required a whole team, which in a very busy trauma center with all that available may be feasible. But in the field, in a small town in Afghanistan, in a medical tent, that's not necessarily feasible. So they thought that they could do better, and so they developed the Reboa catheter that we know today, which is a catheter that is wireless, can be inserted easily through a small sheath, a 7th French sheath that can be obtained under percutaneous access, either with ultrasound or without ultrasound, and can be inflated in the aorta at particular locations. So this is the sheath this is the ER Reboa that we have today. It's made by Prytime Medical. And What's different about it is that it does not require a wire. It has this P-tip here, this curl tip that is self-guiding, and it goes up the aorta without a wire. It has the balloon here. It has length markers so that you can measure out how far that you are in. It transduces an arterial pressure proximal to the occlusion so that you can see or get an assessment of how you're doing from a resuscitation standpoint. And it can be placed through a small sheath, a 7 French sheath that can be, like I said, either gained under ultrasound guidance or without the ultrasound. And in 11 easy steps, you can have control of the aorta through femoral access. And it can be placed in several spots depending on where you think the bleeding is. It can be placed in zone 1, zone 2, or zone 3. And these can be done without fluoro. You can measure this on the patient from the sternal notch or the xiphoid in order to get a rough estimate of which zone you're in, and you can place it without having an x-ray. It's nice to have an x-ray afterwards to confirm placement, but it's not necessary. And so these were trialed in a animal model. They had good results. They had increase in systolic blood pressure, as you'd expect after they're placed, and they gained FDA approval. And this would start what I like to call the pendulum of new technology, where as we get more and more information on these, the positives become negatives and the negatives become positives, and I don't think anything's been truer than with the Reboa. In the early years, most of the research that we have on Reboa was pretty limited. Case studies, small prospective studies, and most of these were not with the catheter that we know today. Most of these were since traction had gained with aortic occlusion with the coda balloon and long wires and sheaths. And you can see that their results are a little bit hard to interpret. We have mortality rates from 0 to 100%, which is not ideal in terms of figuring out if these are going to be a long-term solution. And so we needed more information, and that information originally came from this paper. This is a paper out of Tokyo, Japan, and they had 180,000 patients in their trauma registry, 12,000 that met criteria. They propensity matched 625 patients to Reboa and 625 without Reboa, and they found that Reboa had an increased risk of mortality of 15%. And just to keep this in the back of your mind, this is their time from door to OR, definitive care. Reboa group, 110 minutes, 97 minutes, and so they concluded that the Reboa had excess mortality. In the United States, similar trials were done. This is one out of the aorta registry. This had 114 patients, and they concluded that the balloon could be used as a viable alternative, but there's no difference in mortality. And this was echoed in this paper here, another one out of Tokyo, Japan, which said that Reboa patients and resuscitative thoracotomy patients had no significant difference in mortality. And so like Dr. Hughes, these results were not good. It was a little bit disheartening, and it almost sounded like the death of Reboa, but not all the results were bad. There's papers out of France, this is a 20-year experience, showed that they had decreased mortality with Reboa, especially in pelvic fractures. Another one out of the World Journal of Emergency Surgery showed increased survival. And then if you go to the Reboa website, they'll list all of these, which most of these are case studies, and not a whole lot of large studies, either retrospective or prospective. And so early on, with all this conflicting information, there was a literature review, and this was done of over 1,000, or over 1,300 patients treated with endovascular balloon occlusion of the aorta. And this is what they found. They found that, well, they really couldn't say anything because there was too many differences. There's differences in providers, whether they were radiologists putting these in, anesthesiologists, surgeons, vascular surgeons. There's differences in techniques, whether they were open femoral cut downs, whether they're using a 12 French sheath, a 10 French sheath, whether they were using the CODA balloon, whether they were using percutaneous access, where they were getting access, whether it was in the ER, was it in the IR suite, was it in the OR, was it in a hybrid OR, where they were occluding the aorta, was it in zone 1, was it in zone 3, how long they were occluding the OR, or the aorta, the mechanism of the traumas. These included, especially in the large Japan trials, patients that were actively coding from penetrating injuries, and the arrest status of these patients. And so it was hard to really make heads or tails of these results. And the differences were significant. When you look at these difference in access time, as you'd imagine, people that got early access had improved survival. Differences in sheaths, these big 12 French sheaths that they were using in Japan had significantly more complications and significantly higher mortality than the 7 French sheaths, but they actually got approved 2 years earlier than the U.S. did. And the ability to actually get access, the 12 French sheaths had significantly more problems. They achieved 100% access rates with the 7 French sheath. And differences in occlusion times, whether these patients had total occlusion or partial occlusion or intermittent occlusion. All of these things played into these different studies and made them hard to interpret as a whole. So if you go to the American College of Surgeons website and you look at the Committee on Trauma, they released a new joint statement, and when they looked at all this, they found the same thing. So there's a caveat when you read this. There's no high-grade evidence for Ebola right now, and the evidence that we have is limited and it's ongoing. But in patients that have life-threatening hemorrhage from below the diaphragm, the Ebola is a reasonable alternative to the resuscitative thoracotomy. And this was echoed in the military guidelines, which were just published in 2019. These state that the balloon occlusion of the aorta is a procedure that is supported by trained physician providers as a part of a resuscitation team. It can even be done by advanced resuscitation providers in the field, provided that they have a trained physician that they can get these patients to. And it goes into occlusion times for the Reboa, 30 minutes or less for zone 1 occlusion, up to a maximum of 60 minutes. Zone 3, similarly, prefer 30 to 60 minutes, but can be advanced up to 2 hours depending on the situation. And then this can be extended even further for partial occlusion or intermittent occlusion, where in zone 1 you can occlude the aorta for 15 minutes, slowly let down the balloon after resuscitation, look at the patients and assess them for how resuscitated they are. If they show signs that they're resuscitated, you can leave the balloon down and continue with definitive treatment. If they show signs that they are still not resuscitated and have ongoing bleeding, you can inflate the balloon again for up to 30 minutes with 10-minute checks with deflating the balloon. So where do we go from here? The newer studies are looking at intermittent occlusion, and they've shown some promise. Inflating the balloon for 10 minutes, letting it down for 3 minutes, and repeating this over and over again until hemorrhage control is achieved. It also looks at partial occlusion, so inflating the balloon only partly to try to get some distal perfusion. Newer balloons are being evaluated. There's the EVAC system. This is the endovascular variable aortic control. This device in real time monitors the proximal pressure in the aorta and will inflate or deflate the balloon accordingly. So if proximal aortic pressures are increased above whatever you set it to, the balloon will slowly deflate to allow distal reperfusion. If there's a sudden drop in proximal blood pressure, these will totally inflate to provide total occlusion. Some disadvantages with these, they show promise in the animal models with reduced reperfusion injury, reduced bleeding, but the problem with these is you don't exactly know how long the balloon's been up. There's no way to really tell. And then develop with smaller Reboas. Primetime Medical right now is working on a 5 French Reboa that can be placed on a 20 gauge wire. One of the downsides of the current Reboa is that it requires a 18 gauge wire, and most arterial lines are 20 gauge, and so if you put a 20 gauge arterial line in the groin, it's a little bit more difficult to change that out to the 7 French sheath. You have to put in a micro-puncture kit and then change that to the sheath and then inflate your Reboa. Moving to the smaller 5 French sheaths would allow you to place an arterial line in the groin and then quickly change that out to the 5 French sheath and inflate the balloon, and also help cut down on some of the vascular injuries that have already come down in incidence since the introduction of the 7 French balloon. But the most important thing is that we need more data. This balloon and the current Reboa system is only 2 years out, and so with the amount of traumas that we get that that have good indications for a Reboa balloon, the numbers that we have right now are fairly small, and so finding really meaningful data is a little bit difficult. There have, of course, been other uses for the Reboa. One of the bigger uses is actually in the OB world. One of our chiefs right now is Timothy Stevens. He's going to be going to UAB for his critical care fellowship. This is a big study that they're undergoing now. This is in pregnant patients that have abnormalities of their placenta, whether they're morbidly adhered or they have previa or bruschetta, or in Jehovah's Witness patients that can't tolerate a lot of blood loss. These patients are getting prophylactic Reboa balloons inserted and inflated, and then after the C-section and after control of bleeding, these balloons are being let down, and they're having good results so far. There have been other uses for the Reboa. There's been studies about using the Reboa for the IVC. So in retrohepatic IVC injuries, placing a Reboa both from the femoral and also from the internal jugular in order to try to isolate the injury and then fix it at laparotomy. This is more so case studies. There's not really a whole lot of data on this. And then uses for other things for retroperitoneal hematomas in a hemodynamically unstable patient. We've used them before in patients that had terrible pancreatitis and had undergone cystgastrectomies and ended up bleeding from a eroded splenic artery, placing a Reboa in these patients in order to try to gain a little bit of time for the interventional radiologist to get to the hospital to try to embolize these. And it serves two functions. You get control of bleeding, and they also have a sheath which can readily be used by the radiologist to gain control. And even outside of the trauma world, this has been used as an adjunct to ACLS for non-traumatic cardiac arrest in order to try to increase cerebral perfusion in these patients. So there's a lot of uses for Reboa. None of them have been flushed out very well. But these are my really takeaway points that's supposed to say May 15th. This was originally a little bit earlier. But Reboa is an evolving technology. We've made significant strides in terms of making the sheaths smaller, making them easier to place, making them so that you don't need long wires. But the data that we have right now is a little bit outdated. It's based on old uses, old catheters, old sheaths, and so we haven't really flushed out what we need to do. Second one is that you need to have a game plan. If your game plan is to just place a Reboa, that's kind of like going to the Super Bowl and your only game plan is to have an onside punt. There's really not much to it. You have to have a plan for afterwards. The Reboa is really just a pause button. It allows you a little bit of time. It controls bleeding for a short amount of time so that you can formulate another plan, whether that's getting the patient to an interventional radiologist, getting them to the OR, getting blood products to the patient. If you don't have a plan besides just placing a Reboa balloon, then you're destined to fail. And as Dr. Barker likes to say, a fool with a tool is still a fool. This is just another tool in the toolbox. It's something that you have to have an indication for. If your patient comes into the emergency room and they're hypotensive, and the first thing that you do is place a Reboa, it may not be in the best interest of the patient. This patient needs to be worked up for chest trauma, make sure that they don't have a tension, hemothorax, pneumothorax, that they don't have a pericardial effusion, that they don't have a ruptured thoracic injury that would only make this worse. And so you have the potential to do a lot of damage with this. And it's not to be taken lightly. Even with the smaller 7 French catheters, there are ongoing injuries to the femoral axis. You can get stenosis, you can get claudication, you can have clots that form and cause you to have a cold extremity. And so you have to have a game plan, and you have to know what you're using this for. And I think this is the biggest one. Only time will tell. We're still early in the data collection phase on this, and it's a phase that's a little bit hard to gauge, because we're not only looking at the newer catheters and the new indications, but we're also experimenting with those indications and looking at partial occlusions and intermittent occlusions and newer balloons that automatically inflate. And so I think that the real test of time will be in the next several years, where we'll actually get some data as to what these are actually doing, and if they're actually providing any good for our patients, or if they're only causing damage. Dr. Burns always likes us to do a cost of medicine, so I thought I would do it on silk tape. I'm just kidding. We're doing it on the Reboa catheter. So the Reboa catheter comes in a couple of different formats. They have a ready-to-go kit that includes both the catheter and the sheath and everything that you need to put this in, and that's the one that we have a price on. And that one's almost $2,000, depending on your institution and how many you're going to buy. There's other options. You can buy the catheter alone, and the sheaths themselves are very inexpensive. They're used all the time for vascular access, for IR, and you can make your own kit. And in terms of cost savings and using money and resources wisely, that's probably the better option. It allows you to look at these patients when they come in the emergency room. If there's a suspicion that these patients have an injury below the diaphragm that they're exsanguinating from and that they need a Reboa catheter, you can quickly place one of these sheaths and just leave it there and not open the balloon and not place the balloon, and take them to the OR. And if they need a balloon inserted, if you get into massive bleeding, you can quickly take the catheter. There's one on all the trauma carts. Place the balloon, get control. Or if you get to the OR and there's a spleen and they were just poorly resuscitated as they came in or were down for a long period of time, you can get them resuscitated. And if it looks like they've stabilized out, take the sheath out and monitor for signs of injury to the extremity. So I'd be happy to take any questions at this time.
Questions, comments? How often are we using this roughly? I mean, in a year's time here, Tyler?
Maybe a couple of times, maybe once a month or so. It's not as frequently as as I'd like to see. I'd like to see more of us placing the sheaths as these patients get here, but actually inflating the balloon is
ready to use it.
Yeah, a little bit more rare.
Okay.
I can think of 3 times I've used it in the year and a half or 2 years that we've had it on the shelf here.
Okay.
Pretty selective indications in my experience, but I agree with you completely, Dr. Kestner, about putting the sheath in. That we have an 18 French A-line available in the emergency room, and somebody comes in with signs of hypotension, has a positive FAST, has a significant mechanism. I think we should be putting the 18 French A-line in and getting that.
Not 18 French, that's big.
I mean, 18 gauge, excuse me, 18 gauge A-line in, and we're not trying to put them on ECMO down there. So put that in, and it's there. I think one of the known contraindications to this in my review of what's been published on the Reboa is if they are pulseless, trying to put a Reboa in is not effective and should be contraindicated. If they're pulseless and you want to work on them, you ought to consider doing an ER thoracotomy and not fiddling around trying to put a Reboa through a cut down or using an ultrasound. So putting the A-line in and getting that ready to go in case the patient becomes increasingly hypotensive. And as you highlighted, we just ordered the plain Reboa kit, and all of the accessories that you need to place it come separately, so we don't have to open the Reboa to get the 18 gauge A-line out, so we're not wasting a Reboa every time we think we might need it. The only other thing that I'd comment on for the junior people is the difference in the zones. You said it, but I just want to highlight it. Zone 1 is if you think you have hemorrhage from somewhere in the abdominal cavity, and you just need to occlude all inflow. Zone 3 is what you do when you have a pelvic fracture. You have an open book pelvic fracture and they're hemorrhaging, and your FAST doesn't show any intra-abdominal fluid, then you would go for a zone 3 placement, and you're going to have a lot less visceral ischemia because you're going to be right at the aortic bifurcation. That's just one thing to keep in mind about if you put it in, you've got to decide where you're going to put it in. You need to have a FAST exam and a pelvic film if it's blunt trauma. The other absolute contraindication to the Reboa is for penetrating chest trauma. If you put this up in somebody who's got a cardiac injury, for instance, you're just going to hasten their demise. So.
What about
Great talk. Enjoyed the history on it. It's fascinating.
In that, Bob, pelvic fracture in particular has always been such a frustratingly difficult thing to get control of, or at least used to be. I think we're doing better with that now that we've pulled the pelvis back together and all that. But that takes some time to get done. Are there any isolated looks at pelvic fractures per se, and where this might possibly have been helpful?
Yeah, a lot of the studies that are in favor of Reboa are actually studies in pelvic fractures.
Okay. Yeah, I would think that would
Zone
be
3.
one of the circumstances where it might really have a substantial opportunity to work well, or is that wrong?
I think it's great. He had a great picture of the pelvic binder and the CUDA up. That one slide was a great example, and I mean that you've got control of pelvic bleeding with that.
I mean, I know we've tried in the past, for example, to get IR involved with using pledges to thrombose bleeding in pelvic fractures and things like that, but that takes so much time, and as an opportunity to at least get everything ready to do that, I was wondering if that might be useful there.
They got a 30-minute response time now that we monitor here within 30 minutes to set up. Now, that doesn't mean they're ready to start in 30 minutes.
You're talking about IR now? Okay,
So
good.
it's improved a lot. A lot of these we do embolize pretty rapidly. Most all of them we do. See a blush on the CAT scan of the patient, they go to IR, they get embolized. We've been real successful with getting them involved and making them sort of toe the line on getting here, and they're here. They do a good job.
That's a great example of how nitpicking the college is in your accreditation for trauma center. You have to report to them your IR response times amongst a million other little
I can
things
remember
like that.
I mean, I sure remember some of those frustrating losses we had in trauma 20, 30 years ago. I remember Dr. Barker and Dr. Greer as chief residents here having those problems. Very frustrating because that was all the patient had was a pelvic fracture, and yet we just could not get control of it.
Our IR team's really geared up these days with the strokes response time and trauma, and they're very cooperative, and they attend our QI stuff.
Yeah,
and
okay, all right.
pushing the envelope.
But as a bridge to get to that, it seems to me this might from the emergency room until you could
Yep.
get there, that would really be helpful.
What you see in that picture is a pelvic binder, and
Yeah,
so if they've got open book pelvis, that closes the pelvic volume down and reduces venous bleeding, and then they've got the Reboa up ostensibly in zone 3, where you position the balloon by judging where the umbilicus is and measuring to that height. So that's kind of like the state of the art right there for pelvic fracture bleeding.
Yeah, sure is, yeah. Yeah, Dr. Dart?
Tyler, I thought that was a fantastic review. Just to expound a little bit on our experience here, two things. Number one, when the residents go out and practice, I mean, I think that a lot of, at least major hospitals have Reboas now available, at least trauma centers. And I think, especially for pelvic fractures, you do have to understand what the limitations are in access of your institution. And I agree. I think this institution, I think the residents get a little bit of a different view. We probably have one of the fastest. I can't imagine an IR response team faster than what we have here, and that is just not the case in even other major
Denver
institutions.
was an hour sometimes on their response times, and that's why they do a lot of.
Where's that?
In Denver.
In Denver, yeah.
They do a lot more packing than we do. I mean, we hardly ever go to the OR and do preperitoneal packing, and I guess because of their response times there, they do quite a bit more of that.
But I've put 3 up in 2 years, and have a mortality rate of 100%. And say, well, that's not true. So one of them, you could probably not count this one. I did exactly what we talked about. I put a Reboa up and never inflated the balloon, and that patient actually lived. It was a hypotensive patient in the ER. The 2 that I've inflated the balloon on both died, and they were both blunt trauma. And what I found is that it's very frustrating because you end up occluding the aorta, and there's no question that it does its job to occlude the aorta. I mean, you watch them go from, damn near arresting to stabilized blood pressure, and at least proximal to the balloon. And then you get them to the operating room, especially if they've got really bad blunt trauma, and the balloon's been up for 20 minutes, 30 minutes, and you're trying to partially occlude it, you're trying to not. I mean, you can get it down to like 1 cc in that balloon, that if you take it down 1 more cc, they're just going to plummet. But then what happens is they get this physiologic derangement, because it's this reperfusion type thing. And in both cases, we've been able to complete the operation, and you feel pretty good about yourself, and the bowel's looking awfully ischemic when you've got the balloon up, and you complete the operation, and then you realize they're totally Reboa dependent. And if you have the balloon up, they're going to have a pressure, and as soon as you try to take it down, they don't, even once you have bleeding controlled. And so you're pouring bicarb to them, and I think those are patients that they were going to die regardless of what you did. And so I think the real trick is going to be, it's like all new technology, it's looking for indications and looking for patient selection. And I don't have the answer to that. I mean, just one thing I can tell you, it's just like cross clamping an aorta. Blunt trauma doesn't do nearly as well as penetrating trauma. And if you've got a gunshot wound to the leg and you put a Reboa up and you can go fix it, they do fine. If you have, I think Don's case, I mean, you're really lucky to get that patient out of there. But
Or just good.
or maybe just good. But if you've got a liver that's in 3 pieces and a spleen and a retroperitoneal hematoma, and the bowel's looking like crap, then they just don't do well. So
There's some of those, once you open them, you're in a dismal situation that just need to call it quits probably. But we need to push the limits as far as we can at institutions like this, and we're clearly doing it, and at least here's one survivor that gets back to that. Yeah, Dr. Parker.
Just a couple of comments. Just to reiterate what Tyler said, you got to have a plan, and you can't just put this up and not have a plan to stop the bleeding. This is a temporizing measure to get you to the operating room. Just to show you how things have changed, this patient came in, got a Reboa in, got a fast, went to the operating room, and he was there in 20 minutes. I mean, literally from the time he hit the door, he had arrested twice and got to the operating room. So, number one, the machine works. It's taken a while to hone it, but it actually works, and it actually, all of our efforts sort of end up saving people's lives. And secondly, got to communicate with the anesthesiologist in the operating room. When you take the balloon down, they've got to be prepared for this backwash of all these products, the potassium and the change in the pH and so on and so forth. So you got to work with those guys and let them know before you take it down so they can pre-treat them with some bicarb and be ready for the events. This guy was really fortunate, and he's not a ne'er-do-well. This guy's an executive in the carpet industry, and he's back to work. You couldn't tell anything he ever had anything
That's
done.
phenomenal. That's
Yeah, it's
very
really,
safe.
yeah. The reason, you might question why we didn't go ahead and do a nephrectomy on him when we had him in the operating room. I could not tell where this hematoma was coming from. And we take a chance putting this up because he had all this chest injury and blood in his chest. And we just did not want to get into any of that because you couldn't tell whether this was a cava or what this was that was bleeding. So that's why we put him up, packed him, took him to IR, and found this big renal blush, and then just used the intermittent inflation of the balloon to get him back to the operating room and get his kidney out. So I just wanted to stay out of that hematoma. He had such massive injury, I couldn't tell what it was from. So, all right.
Dr. Dart wants to say something.
One more quick thing, and when Bob and I went up to Baltimore and did the course, I mean, we used coated balloons. We saw the Rabot at that time, but it was not commercially available, and we made the decision to wait until it was commercially available here instead of trying to do what you see in the picture there, because it was just so labor intensive. You had to have 180 centimeter or 200 and something centimeter wires hanging out in the emergency department, and it was really kind of cumbersome. I mean, it's essentially the same thing, but one of the things that became obvious to me was that they talked about use, and I know everybody's going to go crazy when I say this, and I'm not advocating it, but pre-hospital use of this. And if you really stop and put your biases aside, that's where this actually really could make a difference. And I'm not saying we're ready for that in this country, but the examples they give, for example, in France, and Bob can probably speak to this, but they have a very different system in France. They basically have a physician riding on EMS with them. And so, but you could imagine if you could ever perfect this technology, as crazy as it sounds to us, that you could train someone to put one of these up based on certain indications in the field, because that's where you probably really, especially in the military, could potentially make a life-saving difference.
That's what they're doing in the military now too. That paper,
Dr. Mejia's got to say something.
2019,
Yeah.
they were training training responders to do open cut downs in the Black Hawk helicopters that have cadavers up there. They do open cut downs, put the sheath in, and inflate the balloon before they even got to the hospital.
I just got back from this trauma meeting in Vegas, and a lot of places have the EMART service that we used to have here, that we still have the helmet somewhere. But the physicians are going actually to the field, and they're deploying in their kit. They have the REWA catheters, and I talked to Tyler right before the meeting the other day, and they're doing that. The physicians that are on the emergency response teams, they're carrying a Reboa, and they're doing it in the field, like all these mangled extremities that industrial machinery, that they have to do an amputation on the field, and the patient, they get over there, and the patient is hypotensive. They deploy the Reboa, and they're using it on the field. It's a physician that goes to the field, and we used to have that here, but that's already being done in the States, and it's not crazy. I mean, it's being done in a lot of places.
Yeah, if we ever get to the point that we have a physician oversupply like they do in France, then, we'll have people there. I mean, it's, being a physician is not as big a deal there because there's so many of them.
This actually happens in rural areas where, there's one physician, and the physician is going to on the field, and doing it. Surgeons.
Dr. Moore?
On a side note, the paper out of the University of Florida had Chase and Croft's name on it, so
Yeah.
I texted Croft and told him, and he said, I hope they weren't speaking disparagingly. So the conflict and the pendulum, he said, we use a lot of them here, and I hope he's not speaking disparagingly. So.
Well, for the bit, you want to say something else, Bob?
Yeah, I was just going to comment on the partial balloon occlusion. You alluded to this. Pride Time has another catheter that's trying to get FDA approval right now that has a different design of the balloon for partial occlusion. It's designed to have a more linear reduction of the balloon volume to flow, there's sort of like this exponential increased flow with the current balloon, and that's got some promising results in the animal model, but they think it's going to be at least another year before it's released for clinical use. So that may be a little different twist on this. We'll have to wait and see if that.
I think one of the things I'd have to observe about it, if you look at the history of medicine and surgery in particular, and the sequential development, I like it going back to Carl Hughes. Carl Hughes was a very close personal friend of Jim Pate, who was the chair of surgery in Memphis, and Dr. Hughes came to Memphis several times as a visiting professor while I was there. And he was a fine gentleman and looked at this. But I mean, the point is, somebody had to have the idea to start there, because now we've talked about this in the use of trauma. Similar technology utilized in vascular surgery has really made a lot of difference. I haven't followed the literature since I stopped doing vascular about it, but I think these things are being used fairly frequently in leaking aneurysms and things like that as a bridge to getting your stent in and so forth. I'm not sure about that, but I think that's true. Have you all seen any of the residents been involved with the vascular guys doing that, son? Alan?
Yeah, they'll use it for AAAs and sometimes.
Yeah. So, and that's a patient population in which you're likely to have much higher incidence of success, I would think.
They use a coda balloon.
They're using the similar. The point is, physiologically, from a pathophysiology standpoint, you're using the same sort of thing, right?
But the majority of ruptured aortas are treated endovascularly now. Ruptured aortas.
Yeah, sure.
And so, that's a technique you use to occlude the aorta. A couple of just real quick technical points for the residents. If you take somebody tonight or tomorrow, that the limited cases I've done that I've realized, always prep the robot into the field so that you can have access to it. I mean, you've got to do that. Don't just put a laparotomy drape on and then have somebody trying to climb under the drapes. Just prep it in, because you're going to want to have access to it to be able to use the balloon. You've got to be able to control it to control occluding and not occluding. As Bob talked about, the umbilicus and the sternal notch, this is not rocket science. I mean, you basically pick two landmarks and you slide the thing up. These are people that are in extremis, and so those are your landmarks. And if you think about it, and I got lucky enough to think about it last time, it wasn't great for the patient, but it was good for us. When you go to the operating room and you go to the trauma room, make sure the table is oriented so that you can fluoro if you have to, because if you want to take the Roboa from zone 1 down to zone 3, especially in a multi-injured trauma, if they've got extremities, it's very helpful to have a fluoroscopy, because you can see it and you can slide it down and you can put it right where you want to. You can let the balloon down. You can shoot an angiogram through the end of the catheter and see where you are. So we don't always think about that, and I certainly don't, but it helped the last time I had one of these. So.
Yeah.
They're not. You can't hear them, maybe, but they're putting contrast in the balloon as you expand it, so you know where it is. Yeah, it makes sense. Yes.
You can't get all the contrast out. It's too sticky, and so the balloon won't completely deflate if you put straight contrast in there, and you increase the risk of tearing the artery pulling it out.
One thing that, and that's one patient in which I use it to, if you have a patient that is bleeding really bad and you go to IR, a lot of the times the radiologist is not going to think about putting one of those. So work with that patient and tell the radiologist to put one, because a lot of times they can embolize that bleeding, and you have to go back to the OR, and that happened to me, to do surgery on that bleeder. But if the radiologist can put it for you right there, they have the fluoroscopy and all that, then you already have that in place. So go with that patient to radiology, tell the radiologist to put one for you, and then you can go back to the OR.
Well, I think for the benefit, I didn't introduce this appropriately to begin with, and I apologize, Tyler. Dr. Kester is finishing his year of fellowship or residency, if you will, in critical care, and coming back into general surgery starting in July. or I guess it's January.
January, yes, sir.
So one of the things we do with all our fellows and graduating chiefs is they give a Grand Rounds talk. So this was his Grand Rounds talk, which was very expertly and scholarly done. Congratulations on a beautiful job. The other thing I would want to be sure everybody knows, because I know everybody was busy last Friday and couldn't get there, but the Residents Research Day has been changed into a safety and outcomes more based program. And the paper by Dr. Couch and Dr. Morin was selected as the best one. I didn't get to see the others, but I saw theirs, and it was a really great example of actually doing something not just to get an academic accolade, but doing something that had a positive benefit to patient outcomes, which is as most everybody knows here, that's our mantra. Let's start with the patient, try to make the patient better. If we do that, research comes, education comes, and so forth. So it was really well done, very well received. So congratulations to them. I know Morin just had to leave and Couch is on vacation, I think. So good for them. Anybody else have a comment or question? Well, excellent. Well done job, Tyler. Thank you very much.